My name is Emma Erickson, and my project is titled Vital Extraction from Microvascular Videos. I conducted this project under the guidance of Dr. Robert Edman and Dr. Artur Dabrowski at the Auton Lab at the Carnegie Mellon Robotics Institute. Microvascular videos are a way to monitor patients during surgery. Taken with a camera like the one seen on the left, they use green light to capture microscopic vessels just under the surface of the tongue. The resulting videos look like this, where it is possible to see the red blood cells moving in the capillary bed. Of course, microvascular videos are just one of many ways patients might be monitored during surgery. Past clinical studies prove that vital signs such as heart rate, blood pressure, and cardiac output are crucial for anticipating patient outcomes and addressing patient status appropriately. Unfortunately, some of the data most indicative of patient outcomes is the most invasively collected, requiring catheters and arteries and veins, and sometimes even a partial anesthetic. Even if the data is easy to collect, the sheer amount of data collection sources, the number of monitors patients are hooked up to, is unwieldy and increases the likelihood of accidents or mistakes. A single visual source would be less invasive and require fewer sensors. This leads to our objective. Can machine learning methods uncover underlying signals common to concurrently collected videos and vital signs? In other words, can we predict vital data from video data, given that both share a latent signal having to do with patient status? Past work with microvascular videos has focused on vessel extraction and categorization, because vessels are believed to encode information about health. If vessel flow changes suddenly from consistent to lagging, there may be hemorrhaging in other parts of the body. As a side effect of this past work, heart rate was discovered to be encoded in pixel intensity. In replicating that work, we were able to predict heart rate within 10% accuracy 80% of the time from this visual microvascular data alone. This leads to our dataset. To examine the recovery of a latent variable common to microvascular videos and vitals recorded in parallel, we used a dataset collected through a critical care experiment on hemorrhaging. Pigs were bled and monitored, and in total, the video dataset consists of 52 videos approximately 20 seconds long, with 10 250 Hz vital waveforms collected at the same time. From these waveforms, 12 more were produced using simple calculations and manipulations performed beat to beat. Our methodology was as followed. First, data is pre-processed and video data is featurized in several ways. From there, a random forest regressor is trained to predict each vital from each type of video feature. And finally, the results are obtained by evaluating the R-squared values over a 5-fold cross-validation. Videos were featurized in 3 ways. The first type of featurization is a histogram map of motion features per pixel. Motion features were extracted through 3D convolutions of the video with motion filters. Each pixel is described by a histogram of its motion features, and pixels with higher histogram totals, seen in green, indicate more motion. The second type of video featurization was the average pixel intensity for each frame, concatenated over time. And the final featurization is the discrete Fourier transform of that average pixel intensity, showing the frequency at which pixels changed. With all videos featurized, the next step was to train our model. Each video feature is used to train a random forest regressor to attempt to predict each of the 24 vitals. We used an R-squared evaluation to quantify our results, with 0 representing random guessing and 1 being perfect regression. Here's the result of our random forest regressors trained on motion features. Of most important note is that a percentage of variance in blood pressure could be explained, and this is seen in many different types of blood pressure measurements, indicating that this is unlikely to be random chance. The graphs here demonstrate that across different measures of blood pressure, mean arterial pressure, diastolic pressure, systolic pressure, and arterial pressure, our model did better than random chance, if only by a small amount. Pixel intensity was not very informative for predicting vital signs, and the few vitals with R-squared scores greater than 0, which it represents random, only accounted for less than 5% of variance. Finally, the frequency of pixel intensities in the normal heart rate range were able to predict heart rate quite well, and as well as some information on cardiac output, as demonstrated here in these graphs, which show the percent error differences between random guessing and the trained predictions. Future work on this project might explore other data sets, investigate predicting outcomes rather than just vitals, and filter out easy-to-attain information such as heart rate from the videos in order to zero in on more invasive methods that we are more interested in. This material is based upon work supported by the National Science Foundation under grant number 1659774, as well as by a CMU Robotics Institute Lab Scholarship. I'd like to thank the Auton Lab for their immense support, particularly the mentorship and guidance of Dr. Robert Edmond and Dr. Artur Dabrowski. I'm also grateful to the RISC program advisors, Rachel Burson and Dr. John Dolan, for the extreme coordination and effort necessary to make the RISC program possible in the summer of 2020. Thank you.